So ladies and gentlemen, welcome very, very warmly and very, very much to this already sixth Secret Pancreas Cancer Academy that we have the pleasure to hold. I'm Krs Wild Type. I'm president of the Center for European Cooperative Oncology Group and have been active within the field of medical oncology for many, many years. Some of you who are submitting one or the other paper to ESMO Open might know me as a very strict editor-in-chief of the journal, so don't ever try to submit anything because this will be rejected right away. No, I'm only kidding here. So we're very welcome if you want to submit something to ESMO Open, please do not hesitate to do so. Yesterday we had a conference with the ESMO leadership and we're expecting to have an impact factor of going up to almost 7 by the end of this year if everything goes well and everything goes correct. So once again, welcome very warmly. It is our privilege and a very, very long tradition that we have to hold this Pancreas Cancer Academy here in Vienna. We were one or the other time we were outside, but right now during the times of COVID, we have decided that we would rather stay here because things are a little more easy for us to handle organizational-wise and to make a safe environment for you. Now, as I said, we have a long tradition. I remember very well the first Pancreas Cancer Academy had the idea, and this was furthered and even much more built than even thought of previously, has a tradition of being intraprofessional than interprofessional, meaning that we want to concentrate here all kinds of stakeholders dealing with the problem of pancreas cancer. This includes, of course, and foremost, patient advocates, because that's what the whole thing is all about. Then nursing staff, nurses who are dealing with patients having pancreas cancer, and then, of course, physicians who are trying their best to overcome or to control for this very serious disorder. This ranges from basic science, as we'll hear very soon during the upcoming lecture, goes through surgery, radiotherapy, chemotherapy, medical oncology, targeted therapy, immunotherapy, all these aspects ranging up to molecular biology, where we are really very fond to have a series of new insights in the biology of pancreas cancer. Now, while being on this way, we were very, very warmly and very much supported, particularly by Xavier and by Lene and Fabienne, who are sitting right there in the back, who have helped us extremely and shared our vision of having this interdisciplinary and very interprofessional conference, and in fact having a USP concerning pancreas cancer. Because, as you all know, there's almost no conference which deals with this exclusively and which covers this from all the sides that we are trying to do so. Now, my special thanks, of course, go to Gerhard Prager, who is sitting over there. There's a couple of things which are really a great pleasure in your life. One is to have somebody who is a student and then is an assistant and then he becomes a professor and then he becomes important. And that's what Gerhard Prager was. So I'm extremely proud, personally extremely proud, to have such a wonderful person who somehow fell from heaven. And he has been doing the programs, the scientific programs, he's established the faculty. So whoever wants to thank me for inviting somebody here, don't thank me, invite him, because I would not have invited you anyhow, because if he wouldn't done this, I wouldn't have done it, right? So he's the person. And in the end, I want also to thank the CCOG staff. This is marvelous. Ms. Fisher, who might be somewhere.
who you were corresponding with all the time. Now, sponsors were, as I said before, Servier as the main sponsor, but also AstraZeneca and Novocure. So thank you very much for making this possible in tough times. Our 5th Pancreas Cancer Academy, the one preceding the 6th one, was held online and virtual, simply because of the reason, because we did not want to desert anybody. We wanted to continue this, holding this torch up, that we were in contact with you all, that we wanted to continue this and show our commitment to furthering the insights of this still terrible disease. So the 5th Pancreas Cancer Academy was a virtual one, whereas the other 4 were held live. So the 6th one is now concentrating and elaborating further on all the aspects that I have mentioned before. So I'm very, very happy to welcome again patient advocates, nurses, and the faculty, the medical faculty. Thank you very much for coming here to Vienna. And I apologize for all the difficulties that you might have, be encountering in contact with the coronavirus crisis and its containment. So we have a couple of restrictions. Unfortunately, we cannot go out this evening to another place, which we're always used to go to a fancy place somewhere in Vienna, but we're unable to do so. So we'll have a meeting here at the hotel. And all the other household issues will be discussed will be presented to you while we're proceeding. Now, you might have received the QR code. The QR code contains the entire program and the faculty and all the other aspects. And in the end, I want to come to a rather sad story. We are, of course, as many of you are exposed to the very severe Ukrainian refugee crisis, where we are having right now 65,000 people from the Ukraine and Austria. We are extremely challenged by, as oncologists, by people coming in who have cancer in their countries and who have to be treated because they feel threatened, that they cannot be treated here anymore. So we are extremely challenged by delivering all this care to these patients, or patients to be, in fact. You can imagine for Austria, which has 9 million inhabitants, 64,000 is almost the size of Salzburg, which is a major city. And we're expecting 200,000 people to come, which is the size of Graz, which is the 2nd biggest city of Austria. And this is, of course, an enormous challenge for the health system, because nobody expected that this would ever happen. So we want to just to clarify this a little bit and also lobby within the European Union concerning the cancer plan and perhaps a modification of the cancer plan because of the refugee crisis. So we want to ask you for your help. You have a questionnaire which you have received, and we would very much like your help in this context to please show us whether you've been treating patients already or whether you expect to treat patients. And we would, with this, we might, if there's enough answers, we will go with this to the health commissioner, as we were very much involved in the health cancer plan, or the cancer plan for Central and Southeastern Europe with the European Commission. So we want to accentuate this a little bit. As you all know, Central and Southeastern Europe is our sort of home. So thank you very much once again for coming. Thank you for your cooperation. I very much hope that you will enjoy the next 2 days. And I hand over to Gerald. He's the boss. So be nice to him. Thank you very much.
So thank you very much for the very warm welcome. Indeed, Christoph is a mentor. You can call him my clinical mentor, and I've learned a lot from him. I'm happy to welcome you here today. I think it's very good to see you in person again after 2 hard years in looking to our computers for remote learning, remote interactions, and now we have time for personal interaction. I'm happy that I can announce a program which we can call multidisciplinary. We put all our efforts in the aspect how we might treat our patients with pancreatic cancer even better in the future. And I think it's very high consistent that we need a multidisciplinary approach. And for that, I'm very happy that we have today speakers, experts, on the one hand from different countries within Europe, and we have also experts from different disciplines. We have patient advocacies, nurses, and this, I think, makes this meeting so special and different to other meetings. That we have, on the one hand, the opportunity to learn from experts, and on the other hand, to have the interactions multidisciplinary. And so I don't want to talk too long. I would just to give you some overview for today. As I mentioned, we have 3 different tracks. Clinical oncology, we have the nurses, and we focus the need of course, our patients. We give a light into different stages of the disease, the resectable, the borderline resectable, but of course also the metastatic disease. And we want to discuss unmet needs. We want to discuss palliative or supportive care, nutritional aspects, and of course future developments and emerging therapeutic strategies. Just as an overview, CCOG has an Academy for Education, and this Pancreatic Cancer Academy is part of the CCOG Educational Academy, where we have these 3 tracks. So I'm happy to announce now the 6th Pancreatic Cancer Academy, and as I mentioned, for the doctors, we have experts whom I do not have to introduce you. You might all know them, like I put it in an alphabetic order. Thierry Conrad from France, Eric van Kutzenbach, Talia Golan, Israel, Teresa Macarola. From Spain, Julien Taïb, France, Professor Strobe from Vienna, Harpreet Vassan, UK. And then we have also the case presenters, also GI cancer specialists, Ossian Dagisadeh and Florian Huema, both from Austria. So for the doctor's topic, short overview, we first in this joint track, we shortly want to discuss the experience on COVID-19 and how this affected the diagnosis and treatment of our patients. And then we will have a talk about personalized treatment strategies, especially upon molecular profiling, the perioperative management, but of course then also sequence of palliative treatment and new therapeutic strategies. We put a focus on different formats like patient cases, state-of-the-art lectures. We should have time then for panel discussions, and tomorrow morning there will be breakout sessions where you can meet the specialists if you have questions or want to ask some case discussions. So there will be some time between breakfast and then the lectures to meet the experts. As I mentioned, the auditorium, so you are from all over the world. It's also a hybrid educational event where also we have participants online, those who were not able to come here to Vienna. And now I want you to enjoy this Pancreatic Cancer Academy. Thank you so much for your attention. So in the first part, and I think we have some minutes left, where I would like to ask the discussions just to share their experience on they have made in their centers on COVID-19, what we have learned from it, how was the first wave of the infections, did this lead to a delay in diagnosis and treatment, what your centers have done to accomplish this challenge, and what will be, in your perspective, the future, how we can better manage patients if there should be other waves or other strands of COVID-19, how we can manage not to delay diagnosis and treatment of our patients. So may I ask you to come here, Talia, Brett, Gary. To tell you, nobody was prepared to this, so it just a little bit sharing your experience. So I can tell you from my side, from our center. So 2 years ago, everybody was very much, let's say, paralyzed from the first wave. So we stopped surgeries and therefore also some diagnosis, but this was 2 years ago. And then we had to learn how to test patients when they come into our centers to avoid clusters of COVID-19 infections and to prioritize diagnosis and treatments, especially in an aggressive disease such as COVID-19. Who wants to start? Talia, you have the microphone already in hand? Okay. You know, we have to say, at least in Austria, we were very much looking on Israel because Israel was the first country with a very broad vaccination program. And so we were all looking on Israel, how they accomplish this challenge of COVID-19. Do you want to share your experience from your center? No.
Kann man Hilfe haben, bitte? Technik?
Oh, yeah, that's good. Okay.
Okay.
So I think that it's kind of two-sided. I think that we, as a country, are very, we have expertise working with changing situations, and sometimes, you know, if it's a very, how can you say, extreme changing environment. So I think our initiation or our startup, our active startup time was quicker than most countries because we've had wars and we have terrorist attacks. So we, you know, it comes from that because we engaged the army and the army services and into actually the response very, very early on. And I think that was one thing. That was kind of the initial step that facilitated afterwards a quicker response in most countries. From that moment, I think there were two things that made a difference. One is that all our patients in Israel are part of health services, and there are 3 big health services. Majority of them are in one of them as well, and it's digitalized. So our ability to get to patients, to give them vaccination, and then to actually capture knowledge in a digital manner was very, very quick. The government took a very proactive effort from an innovative perspective about taking a forward step of, you know, accepting the vaccine or at a very early stage and implementing it well in the country. The implementation was facilitated by the way the health system is traditionally just built up. So I think that this was the first initiative step, the innovative way to accept changes and to make them, to facilitate them, and then to capture data. I think what we've learned as a country in Israel, and I think we should all learn this, is the impact of digital health, because it can really make quick turnaround times of impacting additional decisions in the medical world. And we, I think, all have to put a lot of emphasis on that. Personally, at our institution, our management was very, very clear from day -1. I can even tell you, like on a personal point of view, that as the shutdown happened, 2 days before the shutdown happened, the whole, we were about 7,000 people at our institution. We all got WhatsApp or SMS messages. Whoever needs daycare for your children for the next few days, tell us the ages and the hours you need so that you can come to work and work. So there was an expectation that we would be at work every single day and that they were going to help us with our children because schools were closing. So this was a very clear message, right? When you get that message, and you know what you have to do. We were told not to compromise on any medical oncology care for our patients. Surgeries were not cancelled. All surgeries were done. Some, obviously, things that were not urgent were delayed. We didn't delay. The only thing that we turned to was digital meetings with our patients if they preferred not to come in. So they had an option of coming in, but if they wanted to, a platform was put out that we could speak to them on the phone or have a video conference with them. And the second very clear message, and this is from our innovative and IRB officers, that all clinical trials would carry on running, including phase 1 trials, including biopsies, et cetera, et cetera. So I think it was, if you think about how things worked in our country, I think it was from the government, from the army being involved, and then from just the way the institution, the country is set out from, that's, you know, the way the health basket facilitates the country's health system. So I think that's what made it a little bit different, and maybe, as you say, we could learn or, you know, help other countries as well.
Excellent. It sounds like an ideal scenario, yes?
It's not ideal, but I'm trying to summarize it.
Mr. Strobel, did you, at that time when the pandemic started, you were in Heidelberg, Germany, in the biggest pancreatic cancer surgery center, excellence center in Germany. What was your experience in this center?
So in Heidelberg, we first, but only some weeks, we had severe, we were very cautious to operate on patients because of intensive care capacity and so on. But we quickly adapted to the situation, and then, of course, the surgeons prioritized patients and operations, and cancer patients had a high priority. And I moved to Vienna in the beginning of 2021, in the middle of the COVID crisis, and I always, I mean, the whole situation was, of course, always influenced by COVID. And I have to say, it's interesting that in the different waves, the effect on how COVID affected surgery was very different. In the autumn of last year, we had a shortage in intensive care because the patients needed intensive care, and this was the shortage. And I have to say, within the hospital, we had an excellent way to distribute intensive care capacity and prioritize patients interdisciplinary. So this was, I think, by a very good coordination, I think we did a good job to provide care to patients, although there was a shortage. In the last wave now that we just have behind us, the situation was very different because patients were not so ill that they needed intensive care, but now the personnel was sick themselves, or at least infected and had to stay at home. And we had a shortage because of this mechanism. So I think the situation is very volatile, and we have to adapt quickly to new situations. And I think overall this went well, but looking back, you always can criticize what has been decided also by politicians.
Yeah. You want to hand over the microphone to Hapred. UK was also very much affected by COVID-19 waves. So what was your experience, at least in your center?
Thank you. So, I mean, there's a lot of overlap with the other speakers in the way it was affected. So I'm going to take it more from probably a patient perspective. I think there were some real negatives in the first wave from March 2020, because I was working at a center which was leading research in COVID, and all our staff got redeployed to COVID care, not just cancer patients, including our research teams, because we suddenly started lots of research trials in COVID, which were nationally funded. So our research got hit from that angle, given that we do a lot of clinical trials, but we also got affected by patients who were very nervous about coming up to a high-intense COVID type of hospital, because we were taking the sickest patients in London. So it was very negative for pancreatic cancer patients, particularly when you think of the regimens that we use are very intense, and then we had to build in COVID testing into those systems, and the blood testing had to be done a little bit more in advance than we would normally do, which changed our schedule slightly. So we did implement quite a lot of changes in terms of hierarchy. I think that was alluded to in Heidelberg. We had stratification for surgery, and we had stratification for chemotherapy, part of which was national.
And there was guidance also to think about using more, and certainly I took this on, more GCSF, for instance, to try and stop hospital admissions, which actually we've implemented very well. In the second wave, I think we were much more positive because there were things that the NHS, being a massive organization, moved so quickly that we never thought it could be done. So, for instance, digital health that you described, particularly with patient interaction. Things that they were worried about with data protection suddenly became not a problem anymore. And in fact, we've now implemented a really nice hybrid model of patient care. So there have been some positive accelerated events that have occurred that have definitely improved the health system. But in terms of pancreatic cancer patients, for instance, we had to shift some patients from gemcitabine paclitaxel, or if we were using 2-weekly FOLFIRINOX, we had to ask them whether they would want to shift to a less intense regimen such as GemCap, which is not a favorite regimen of mine, but we had to do some holding measures because we were really overwhelmed by the number of patients. I would say that about a third of our patients over the age of 70 also decided where they may not have, they decided to go for palliative care rather than have active treatment, which is very unusual in our catchment. So I think there were some positives that have come out of it, but the patients, I think, in the first wave, in the first 6-9 months, were very badly affected.
Okay. Eric, you're overlooking probably the most clinical trials in GI of ours. So what was your impression? How much were clinical research affected by the pandemic?
I think it's probably different from country to country. Belgium was very much affected by COVID, like many countries, but cancer care was prioritized. So we, in our hospital in Leuven, we never had to cut down in the first and second wave, which is different with today, on the number of patients that we could see on the day clinics, on the treatments. So we did not cut down on trials. Of course, some of the international trials were put on hold and were given lesser slots. So in total, you had a bit less patients in trials. But for the general treatment, we didn't have to change so much in the first and second wave in 2020 in GI cancer. And in cancer in general, if you look to the cancer registry, in Belgium, there were a little bit less new cancer diagnoses made, around 10 to 15% less cancer diagnoses were made in 2020. In 2021, this was taken up again. So if you count together 2020 and 2021, it's only a few percentage of cancers less diagnosed. Many of them are in the field of, the most frequent was melanoma, because patients didn't just go for their check to a dermatologist. We stopped in Belgium also colon cancer screening, the national screening program, for 2 months in the first wave, for 3 weeks in the second wave, and afterwards we continued. If you look at the number of patients and diagnoses in pancreatic cancer, that was almost not affected, because these patients are, when they are diagnosed, usually very symptomatic. So anyway, they go to see their physicians. In our hospital, we have 2,000 beds. In the first wave, we had at a maximum 140 in-hospital patients. So especially orthopedics, ophthalmology, and these departments with less urgent medical treatments, not less important, but less urgent, they were more affected than in oncology. Now, in what we call the fifth wave, which was at this summit 2-3 weeks ago, we had 169 patients in the hospital, which is identical, the same number as in the second wave in November 2020, and which is more than in March 2020. But the difference is that there is less intubated patients, less ventilated patients. But the impact on care in the hospital was bigger, because the personnel was, you get more people, nurses and medical paramedics who were sick and who had to go in quarantine. So also looking at burnout rates in nurses, Of the people, we have 10,000 employees in the hospital in Leuven. The burnout rate is now higher than it was in 2020 because of the different waves, and some people just went into burnout because of the stress. Two, there is becoming an increasing problem in our country of, like in many countries, I guess, especially for nursing staff, that's becoming very difficult in this situation. And that affects, that's why now at this moment, still in the hospital, some of the care has to be delayed. In oncology, in our treatments, in chemotherapy and so on, we don't have to delay, but surgeons have to delay some of the treatments, and then they do the less urgent surgery. So oncology really, treatment of oncology, surgical oncology is not affected, but there's still an important impact on the whole care.
As you were mentioning, nurses had to carry the probably most burden, most stressful burden. So I would like to ask you if you can give us your perspective. Take the other microphone.
Speaking as a nurse in the UK, a clinical nurse specialist in pancreas cancer, mirrors what a lot of the panel have said. In the first wave, there was a lot of fear. From our nursing perspective, a lot of our staff were redeployed. I spent 3 months, 2 days a week working purely on palliative care COVID wards, which I'll talk about in the nurses session later. I think one of the main things personally I found difficult was being told by the institution I worked at that the clinic I ran for inoperable and metastatic patients for new diagnosis, we weren't allowed to see them face to face anymore, which we pushed back against, and soon we created a separate unit where we could see patients face to face. And I think as a nurse, not being able to interact with a patient on a face to face basis when you're breaking bad news was very difficult, and mirrors what a lot of patients have told us as well. I think at the moment, mirrors what people have said. The main thing we're seeing now is staff sickness, staff isolation, and there's a lot of fear amongst surgeons I work with and nurses I work with about getting COVID, so they can't do their job properly. So it's common to come into work and the surgeon who's supposed to be doing a 12-hour case maybe have rang up during the night that their child has got COVID and they're isolating, and it's having to switch around and plan things at the last minute, and it's trying to look 10 steps ahead, really. And I think that's probably what we've all tried to do.
Okay. Thierry, may I ask you to
yes, thank
share
you.
your experience with us?
The experience in France, where the first wave was at the middle of March 2020, is very similar to Belgium, and was director of a comprehensive cancer center. So we organized everything in February with limitation of visit, one entry in the hospital with a checkpoint, hand washing, and so on. The most difficult point was to get masks and to organize a COVID unit only for our patients. The main problem was the complete lockdown of all private institutions and physicians, and all the screening, endoscopy, and radiology was stopped for months, so there was a delay in diagnosis. So we published in ESMO Open the results of all comprehensive cancer center and France with less than 10 to 20 patients, so which was not diagnosed as cancer, with delay, and then more diagnosis of a metastatic disease or locally advanced pancreatic cancer. We have also very large difficulty to access to surgery in large university hospitals and large clinics. So in our institution, we organize surgery for the other institutions, and physicians and surgeons from the university hospital went for surgery for their patients in our hospital when it was a cancer diagnosis, and we have to cancel all the surgery which was not urgent, like breast reconstruction, to leave some places for pancreatic esophageal surgery, and which was more urgent. So it was a difficult organization, and we have staff with all the other hospitals twice a week, with other cancer center weekly, and within our institution, physicians, nurses, and have to meet in each department twice a day to organize prioritization of healthcare for the next day. Then at the beginning, visit was not allowed, and we give tablets to patients to speak to their family. Then we, of course, visit to patients in palliative care was authorized, but this was difficult with limit to one person. So now with ventilation, we authorize 2 visits a day, but as in Belgium, the 5th wave is more difficult than the previous one, because there's a lot of personal nurses which are ill, and we have not enough personnel. So we have to close parts of units, but at this time we have no delay in surgery, or chemotherapy, or radiotherapy. Patients who had COVID are treated with radiotherapy or at surgery at the end of the day as the last treatment of the day, to permit disinfection and to provide necessary protection, safety for the other patients and staff.
It's very important also to mention that there were restrictions in many centers in many countries for relative visits. So many patients were isolated for many days in their units. And so would you like to give us the patient's perspective from the patient advocacy side?
First of all, as you know, Italy has been the country that has been affected most dramatically in the first wave. So that's make a different scenario. The main issue has been communication. So the communication from the authorities has not been very clear, mostly ambiguous, and that has created panic in the situation. At the point that in March, in the second half of March, we launched a survey in the patient community, not just pancreatic, and we got the response about the kind of problem that we're experiencing. So chemotherapy and radiotherapy was almost okay. Surgery was dramatic, 62% decrease. I think it's most similar to what's happening in other countries. The follow-up as well, the screening, and for the particular situation of the healthcare in Italy, for instance, for pancreatic cancer, most of the excellence centers are located in the north, and there is a lot of people that are traveling from the center of Italy or from the south to the north Italy, and that has been completely disrupted. So in many respects, in some respect, digital health, in particular telemedicine, has been alleviating the issue, but I mean, for surgery, for whatever, I mean, that could be not possible. So the good things of COVID, that finally the authorities had understood the relevance of digital health that has been completely dismissed in our situation. The issue of the communication, it's a very important issue. I mean, in any pandemic situation, in any problematic situation, I would say, you have to address communication in a very clear way, because the community, the population is subject to different messages. And I don't know how it was in the other countries, but even the medical community in the talk show, they were, I mean, giving not the best that they could provide in terms of information. So from our point of view, I would say bear in mind that communication is a key point in dealing with the pandemic. Just to answer your question, I mean, the problem of the patient visit of the relatives has been a huge, huge, huge problem, even because in the what we call the hospice on the situation for old people, I mean, that has been dramatic.
Yeah, absolutely right. In respect of time, we have continued within our program. So thank you so much for this comprehensive discussion, giving your impression and perspective how you did handle the pandemic so far. Thank you so much. So we have seen in many solid tumors that precision medicine became an important role in the treatment, new treatment approaches for solid tumor diseases. However, pancreatic cancer was outstanding in a negative way because we know that most of adenocarcinomas of the pancreas have a RAS mutation, but most likely we are not there yet to target this. And then recently, a very exciting clinical phase 3 trial, the Apollo trial, did demonstrate that there are a subgroup of patients who might have a benefit of a targeted treatment in the metastatic setting of pancreatic cancer. And this achievement is most due to Talia Goland. I'm very happy that she's here today, and she will give us a summary of her research and the perspective how we can in the future treat the patients according to their molecular profile. So thank you so much making the way here to Vienna.
Not all of us are as tall as Gerald. Sorry for that. Okay. That's good. You can hear me. My slides come up. Going to happen. So I just want to say that it is such a true privilege to be here, and I mean this with all my heart. Multidisciplinary approach is utmost important in all cancers and in all medicine today, but I think with such a devastating disease with pancreatic cancer, and I feel almost embarrassed to say that word in the setting because all of us feel it with every cell in our bodies. I work with a phenomenal team, a nurse and a physician, and I would not be able to do this by myself. And that's why this meeting that you have done, which is, thank you.
Can we have the slides, please?
In my slides, yeah. Maybe you should put it down here because it's... So this meeting that is really a merge of physicians, scientists, nurses, and patient advocacies. It doesn't happen. I don't know if you know, but this is really unique, and I think it's, and I'm really, really happy to be here and to present my data. We are a diverse group of people together, so I have tried to plan my talk that it will be clear to everyone. And I have a lot of case reports of different patients that reflect some of the ideas that I'm trying to bring forward. So really I'm going to speak about personalized treatment approach based by precision medicine in advanced pancreatic cancer. These are my disclosures. The outline of my talk, I'm going to speak about FDA-approved drugs, how we do profiling, and then kind of what's happening in the future. This is the arsenal of drugs, right? This is what we have to treat. This is a very limited arsenal of drugs. In orange, one can see the chemotherapy and elatinib, which is a biological agent. And in green, one can see the biomarker-driven targeted therapy. If you compare this to lung cancer, breast cancer, we are really, way behind. And as a community together, we've still got a lot of work to do. So why is this happening? This is a very disappointing slide as well. It shows probably the majority of clinical phase 2, 3 trials in the last 5, 6 years that were negative. This is over 4,000 patients, all negative trials. Most of them were not biologically or biomarker driven. So when we speak about tumor genomic profiling, what does this mean? This means that we can take DNA from a sample of the tumor and we can check the mutational status. There are different levels as we do this. There's whole genome sequencing, which is the deepest level. Then we have transcriptal signatures. These two are more used for research activities at this stage. And what the majority of us work with are commercial genomic patterns. So these are capture-based profiling of cancer-related genes, intron regions of specific genes rearranged in cancer, and then we also get tumor mutation burden and microsatellite densibility, the NGS report that we all used to, and this is really what I'm going to talk about mostly here. So based on these genomic profiling, we know that the most consistent mutations that we see in pancreatic cancer are these 4 mutations, the KRAS mutation, the TP53, the CDKN2A, and the SMAD4. So these are very homogeneous and very prevalent. But then actually, pancreatic cancer also has high level of heterogeneity with additional targetable mutations, but these are really present at very low levels. So in a way, my talk really reflects that small percentage. So I want you to remember that my talk doesn't really reflect what we're seeing every day, but it does give us hope of where we can go in the future. When we talk about mutations, we talk about somatic alterations. This is the majority of ones that we're going to speak about, but then we do also have germline, for example, the Lynch syndrome and also the BRCA genes. So firstly, I'm going to go through with you the FDA-approved drugs in pancreatic cancer. So the first is the immune checkpoint inhibitors in mismatch repair tumors. The incidence of mismatch repair deficiency in pancreatic cancer is around 1%. Pembrolizumab was approved by the FDA for a tissue-agnostic approach, which means that it was a big basket trial. Didn't matter what kind of disease subtype you had. If you had a mismatch repair gene, then you could be enrolled. So in this pivotal phase 2 study, 8 pancreatic cancer patients with mismatch repair gene, you can see them here in the blue. The responses were really nice. 2 complete responses, 3 partial responses, 1 stable disease. In more updated publications, the responses haven't seen so dramatic. And I'd like to share with you a phenomenal case in my mind. One of the patients that I've been treating, she's a 47-year-old single mom. Her father had recently, about 2 years earlier, died with pancreatic cancer. Due to abdominal pain, she underwent evaluation, including a PET-CT, and we saw a mass in the body of her pancreas that encased the hepatic artery. She had 1 single bone lesion and a retroperitoneal lymph node. Her tumor marker CA-99 were normal. Her CEA was elevated. She was diagnosed with adenocarcinoma. And obviously, there was a suggestion there may be a family history at young age, father, etc. We sent her for NGS analysis, and she had a mismatch. She had an MSH6 gene, part of the Lynch syndrome, and she also had a CHEK2 mutation. So these both were somatic, but they're also germline mutations. She had 2 potentially actionable mutations. Why do I say 2? So MSH we've already defined, the mismatch repair and the checkpoint inhibitors, but CHEK2 is also part of the DNA damage repair genes, and some of these patients actually respond nicely to platinum-based treatment. So we decided to give her, she had private insurance because we're bringing the checkpoint inhibitor forward and we're giving it in combination with chemo. So we're doing something that is out of standard of care. We decided to give her FOLFOX and a checkpoint inhibitor. So here you can see her images. One can see this is a PET-CT. One can see the uptake of her lesion in the pancreas. One can see the lesion in the bone, and one can see her retroperitoneal lymph node. So she's got oligometastatic disease. So we started treating her. This is in February 2019, and this is in July 2019, and this is after 12 treatments of FOLFOX, and you can see there's almost a really nice, strong imaging response. And we decide that we're going to do something a bit different. We decide that we're going to operate on this patient. We're going to do a distal pancreatectomy, and we're going to radio to a bone lesion. So this is once again an unusual thing to do, but we've got an unusual patient with unusual and this is the pathology report, very small tumor left, nice response to treatment, and 13 lymph nodes with no evidence of disease. The reason we decided to operate is that we had also decided together as a multidisciplinary approach that we would also continue treatment with her. So the patient continued to receive a checkpoint inhibitor. And then in May 2020, there was a local regional recurrence in the tumor bed. You can see it there illustrated. So we decided to do SBRT to this local regional recurrence and then to add a CTLA-4 inhibitor to her treatment. 2 years later, this is her imaging. She is NED. She's completely disease-free. I don't know what's going to happen in the future, but this is a really remarkable scenario of using the genomic alterations, the very unique genomic alterations in her tumor to define her treatment journey. And I think that due to the way we treated her, we changed the biology of her disease. Next FDA-approved drug is for Treg, the Treg protein. This is a fusion of a variety of different partners with the Treg encoding genes that activate the MAP kinase and the PI3 kinase pathway. The prevalence is less than 1% in pancreatic cancer, and there are 2 FDA-approved drugs, the larotrectinib and the entrectinib for NTRK fusions. This is very rare. I personally don't have a patient like this, and this is based on very small, very tiny, smaller percentage of patients, and also 3 patients and 4 patients from clinical trials, these basket studies. And now we're going to go on to germline BRCA mutations. So this is a biomarker-driven group. It's about 70% of patients with advanced pancreatic cancer, and in founder mutations, certain ethnic groups can be much higher than 7%. The BRCA1 and 2 are key known proteins in the homologous recombination pathway, which one is one of the very, very important pathways in DNA damage repair. And the BRCA is already a known predictive marker, so we know that they have a nice response to platinum-based chemotherapy, and we know also that we can give them PARP inhibitors. The clinical guidelines recommend FDA and EMA giving PARP inhibitor maintenance in these patients. So what is the data that supports that? So this is retrospective data that shows that when we give these patients a platinum-based chemotherapy, they have an extended progression-free survival and overall survival. I would like to say that we have that you can see that if you do not give them platinum-based chemotherapy, this is really old data. When we didn't know we had to treat these patients in a certain way, they have the same bad diagnosis as the rest of the patients. So this is a predictive biomarker. Okay, it's not a prognostic biomarker. And then it's already well recognized that PARP inhibitors have synthetic lethality in patients with BRCA mutations, and this was demonstrated in the POLAR study. So this was a really huge global effort. Over 3,000 patients evaluated worldwide to identify about 150 patients to be randomized in a phase 3 trial. This was the first phase 3 trial that was positive in pancreatic cancer. And we saw a nice progression-free survival versus placebo. What was really fascinating about this drug is that in the responding patients, in those that had a partial response, this went on for over 2 years. So all of us treating pancreatic cancer, it's quite remarkable to see a patient on a biological agent and this kind of carrying on and on and on. And what's even more remarkable in the long-term survivors, which is reflected here by the swimmer's plot, there's about 15% of patients who are still in complete response. So this is, and we have a few patients like this, and it really kind of, I often say, it kind of gives me wind into my sails that we can just carry on going in this devastating disease. Overall survival is the same in both cohorts, but the hazard ratio favored olaparib, and it's probably due to the fact that the study was not powered to detect. We would have had to screen 30,000 patients if we wanted to see an overall survival. So we'll speak a little bit at the end about how we design clinical trials. But what's most important, so this is a really unique subset of patients, easy to identify. We know how to treat them. But even in this disease, the patients are not responding the same. On the top of the slide, you can see a patient, same mutation, getting the same treatment, beautiful reduction of the liver met. At the bottom, you can see nothing changing. So even here, there's a spectrum. And we have to really think about how we're reflecting that spectrum. And this is a lot of work that we do in our lab. So this is a swimmer's plot of about 100 patients at our institute and treated over the last decade. And you can see a nice swimmer's plot, right? These are all BRCA patients treated with platinum or PARP. And we decided to try and make classification for what we're seeing. So we've classified them in this way. Those who have innate resistance. So even though they have this, and we suspect they're going to respond, they don't respond. They do not respond to platinum and they die in a short time. They have innate resistance, it's about 25% of the patients. Then we have our long-term responders, phenomenal patients. They're in remission for many years, but the bulk of our patients is really the ones that you see in the red box. They have beautiful response, but it goes on for about 1.5 years, 2 years, and then they have acquired resistance, and then they pass away. So this is really the bulk of our patients, and as a research group, we have taken samples from our patients, and we've developed model systems that actually reflect these clinical scenarios. So we have about 25 models that are growing in patient-derived xenograft in mouse that reflect the patients with innate resistant, with required resistance, and then the super responders. And there's a lot of effort trying to think about what the next generation of drugs and how to understand the resistance mechanisms. Until now, we've spoken about FDA-approved drugs. And now we're trying to kind of go into the future and where we're going. We've just spoken about BRCA, so I'm going to stay in the DNA damage repair arena. What about DDR, DNA damage repair beyond BRCA? It's all about definition. This is really a moving target. This is how we thought that a lot of the DNA damage repair genes would also show homologous recombination deficiency, but this is probably not true. This is a list that reflects some of the DNA damage repair, and it's about 10%, but as I say, different studies with different definitions show different statistics. So what do we know currently? Michael Pishwin has showed beautifully in the JCO paper that a favorable response to platinum agent is noted also in patients with DNA damage repair alterations beyond BRCA, maybe like that patient with the CHEK2 inhibitor mutation that I showed you. We did a clinical trial with MD Anderson, an investigation initiative trial that unfortunately was a negative trial published last year, that we tried to give PARP inhibitors to patients with DNA damage repair alterations beyond BRCA, and it didn't work. So what have we learned? Be clear about your definitions. DNA damage repair does not necessarily mean homologous recombination deficiency. Second, even if a patient is responding to platinum, that's not going to mean he's going to respond to another DNA damaging agent. It depends how that agent works. So we're really going to be thoughtful about how we plan our things. And this is just a very quick introduction to about 400 patients of work that we've done with Stephen Gallagher and his group in Canada. We performed whole genome sequencing on patients. We enriched them with the BRCA patients. And actually, the only ones that had an HRD signature are those with a BRCA1 or 2 somatic and germline mutation, RAD51 and PALP2. So none of the patients with ATM or CHEK2 that we thought would have an HRD signature, none of them actually have a signature. And this is a really nice study just out of the oven, as they say. This is Peter Hussein's group from this is lovely retrospective kind of analysis of Ipi/Nivo, so checkpoint inhibitor and a CTLA-4 inhibitor with patients with advanced pancreatic and biliary tumor. It came out last week. And they gave them these two combinations. And you can see here, I haven't got my glasses on. I think we have 4 complete responses and 1 partial responses of 11 patients. And some of these were very heavily pre-treated. So this is really reflecting that we may already have additional options in some of the patients with HRD to go for immunotherapy. Okay, now let's go into the group of Krs Wild Type. 90% of our patients have Krs mutant, and then we have about 10% that have Krs wild type. In those patients, you have a much higher chance of finding an actionable mutation or potentially actionable mutation. For example, the BRAF, the OB2, the Elk, and the RET. So this is what I'm going to show you some examples of this. So the BRAF alteration, this is found in about 3% of our patients, and there's 2 kind of specific mutations we speak about. The V600 family, it's about 3% of the cases, and then an additional non-V600 with in-frame insertions and deletions, about 1%. So I'm just reflecting with you one case report that was published of a patient with an in-frame BRAF mutation, received a MEK inhibitor alone, and had a partial response for 6 months. And then there's another case report, number 2, a patient with a specific BRAF 600E mutation. Eric Van Kootsen, this is one of his papers, showed that a BRAF inhibitor and a MEK inhibitor showed a partial response of 9 months. This was second-line treatment. We had 2 patients with BRAF inhibitors that we tried to give treatment, and they did not respond. There seems to be a lot of heterogeneity in that small subset of patients. Next is the NRG1 fusion. So NRG1 is a cell adhesion molecule and acts on the EGFR family of receptors. Its prevalence is about 0.5%, but if you go to the young PDAC Krs wild type, it goes up to about 70%. Zenocutuzumab is a HER2 biospecific antibody. It docks onto the HER2 receptor, and then it kind of It doesn't facilitate NRG1 binding with HER3. This is a study from only pancreatic cancer patients with NRG1 treatments treated with Zena, and you can see really nice, a lot of stable disease, partial response, a really nice response in the small cohort of patients. And this is also the swimmer's plot, and you can see that the responses were noted very early. So from already 8 weeks, we can see the response. So until now, we've spoken about NRG1. Remember, we're in that very small subtype of potentially actionable mutations. Let's go on to Elk Rearrangements. The Elk Rearrangements are very well known and have made a lot of hype, and correctly so, in lung cancer. There was already first and second and third generations, and it's really amazing. It's an amazing target, an amazing drug. It's seen in about 0.16% of pancreatic cancer patients, up to 1.3 in Krs Wild Type, and then the younger patients. In a case series of 4 patients, 3 had clinical response. I'd like to share with you a case report from us recently, a 67-year-old patient. He came in with abdominal pain, obstructive jaundice. A 2-centimeter operable mass was seen on imaging. CA99 was 218, adenocarcinoma was confirmed, and he was sent for surgery. The surgeon, when he did his laparoscopy, he saw a lesion on the liver that was not detected by imaging, and he took a biopsy, and it was adenocarcinoma. Closed the patient up and sent him to us. We initiated FOLFIRINOX, sent the patient for NGS, and we found an Elk fusion mutation. This is my first patient I've seen at this. I was very excited. And this is his diagnosis. So in February 2021, last year, he was diagnosed. No liver lesion was ever seen, and we initiated treatment. Look how beautifully his lesion responded to FOLFIRINOX. This is an MRI imaging, so really nice down staging. So after 10, 12 cycles of FOLFIRINOX, we weren't sure what to do. Do we carry on maybe FOLFIRI? He's really responding to chemo. Do we change to crizotinib, which is for Elk fusions? And we spent big discussions with the family and thinking about what to do. And we said, we'll give it a chance. And if, the biological agent doesn't work, we'll go back quickly to the chemotherapy. So this is after 4 months. Look how beautifully the tumor is really, really shrinking now on the crizotinib. So over the course of time, it's getting really, really small. And it actually almost disappeared by imaging. And this week on Wednesday, he was sent for operation. Surgeon looked very carefully on the liver, didn't see anything, and the patient had a Whipple operation. There was no clinical viable tumor. We're still waiting for the pathology report. And we had decided as a multidisciplinary team that we will carry on crizotinib post-operation. So once again, really a fascinating case. The next alteration I want to share with you is a RET alteration. So RET can be oncogenically activated by 2 pathways. We're going to have chromosomal rearrangements, or we can have point mutations. So normally in all the solid tumors, we're seeing these chromosomal rearrangements, but then in medullary cancer, we see really specific point mutations. The prevalence is about 1.35 in Krs Wild Type pancreatic cancer, and selpercatinib is a specific inhibitor of the RET tyrant kinase. Another case study I want to share with you from my clinic. A young 45-year-old female, actually a physician, came in with this lesion in the body tail of her pancreas and a 5-6 centimeter lesion in her liver. The pathology report was an adenocarcinoma. It took a long time to get that diagnosis. I know you know how kind of challenging it can be to differentiate. The patient received FOLFIRINOX. We sent her for NGS, and she came back with a RET fusion mutation. We put her onto a clinical trial with the RET inhibitor, and here I can share with you her results. So diagnosed 11/2019, had 4 cycles of FOLFIRINOX, then went on to receive the RET inhibitor, and you can see a nice response, really nice reduction of a tumor. And she is a very active patient, and we weren't sure what to do, and she really wanted to go for operation. We know that sometimes in adenocarcinoma, we do operate these patients. I spoke to the clinical trial. We got approval for her to continue the RET inhibitor post-operation. She went for a metastasectomy, and she went for and resection of the primary tumor, and she continues to be 2 years later in complete response on study drug. Another really fascinating case. Going on to the Krs mutation. So Krs is a non-actionable mutation that's until very recently, the G12C, which is prevalent in 2% of pancreatic cancers, has now a target, adagrasib. It's a highly selective oral small molecule for KRAS G12C. And this is the clinical evidence showing really nice response. A lot of, actually everyone, clinical response in all the patients. It's still now in evaluation, and this is really a small percentage of our patients, but it really maybe opens that window of opportunity that maybe KRAS is not really going to be a non-actionable target. And in the next future, we're having more and more drugs coming up. And for my last really few minutes, I was told to spoke about advanced disease, but I'm speaking a little bit about neoadjuvant precision medicine. So what are our considerations? This is very difficult. We have considerations that are prognostic predictive biomarkers. For pharma biopsies, we can try and evaluate, and we have much quicker short turnaround times now to make these decisions, right? Because you need to make quicker responses in the neoadjuvant session. And then you also have anatomical definitions that are really difficult and challenging to make together as a team. And then you have the biological and conditions of the family and decisions together. So this is just some data to show you that giving neoadjuvant FOLFIRINOX, which is actually precision medicine in BRCA patients, shows really nice responses. It's a retrospective series, but in 44 patients with borderline pancreatic cancer with FOLFIRINOX, pathological complete response was 44% versus about 9% what we really see, and there's the disease-free survival has really been elevated. So actually identifying these patients and demanding that they get their neoadjuvant FOLFIRINOX is precision medicine for patients with BRCA mutations. And I want to share with you two more case studies. And then I'm finishing. I hope I'm on time. So this is just to show you a 45-year-old patient that came in with abdominal pain. He had a mass in his pancreatic head, abutting the SMV, and he had a lesion in his liver and his lungs that were too small to biopsy. We didn't know what those lesions were. So even though he was borderline resectable, and in 2015, he would have been resected, I knew he was a BRCA mutation carrier, and I said to the surgeons, no way, like, you're not touching him till we're giving him some FOLFIRINOX. So we started neoadjuvant FOLFIRINOX, and this is his tumor at diagnosis. So this is May 2015. You can see really kind of nice bulky tumor and uptake, and this is on treatment. It literally melted away, you know, as we treated it. The patient went for surgery, and there was a minimal residual carcinoma. You can see his pathology report. Lymph nodes were negative. We carried him on another 4 treatments of FOLFIRINOX and his NED since then. And this is my last fascinating case report, because I'd never seen one like this. I kind of, you know, when you don't want to show the patient too much, that you're actually excited about what you're seeing, because from like a scientific place, it's just fascinating. But it was very nice couple, and it was really kind of a joint journey together with them. So this is a 61-year-old male, Jewish Ashkenazi. He had melanoma, diabetes, abdominal pain, did CT imaging, showed a mass in the pancreatic head. It was resectable. There was no vessel involvement. And when you looked at his family history, it was really strange. His father had colorectal cancer at the age of 40, and his mother had breast cancer at the age of 40. So there was suspicion here also for Lynch syndrome and also for BRCA, but I'd never seen patient with both of these mutations together. So I said to him, you know, you've probably got one of them, which is great, because that really means we can impact your treatment, but, you know, we'll see which one. So this was the result. He had both of them, which is good for us, right? Good for, well, not us. When I say us, it's the treating side and the patient side, but obviously the family implications of this kind of hereditary complexity is really, really a tough thing to take on. But as I said to him, you know, you're 61 years old. It's already been defined 61 years ago. We're going to just label it. So this patient, this is his tumor, and you can see at diagnosis, and then on we gave him FOLFIRINOX and a checkpoint inhibitor. Which is a bit aggressive. Once again, this is out of standard treatment. We don't know, you know, there's no evidence to support this. You know, we're just thinking about doing precision medicine in those tiny, small opportunities that you have them. And the patient actually yesterday was operated on. He had a Whipple operation. I don't know if pathology reported. I don't know anything. Had a laparoscopy, a lap Whipple. So that's always good. So this is my last slide. what are the barriers to implementation of precision medicine specifically for pancreatic cancer? One, we have a real problem. I've kind of highlighted things that are specific for pancreatic cancer, low cellularity. The percentage of cancer cells in our samples is around 20%. In breast cancer, it's about 60-70%. So we really have a technical problem of sampling, and then of the samples that we get, how do we really do how do we do genomic sequencing in an adequate way and get information? And then the second is the technology specific thing of core data interpretation, definitions. This is a moving target, how these definitions are changing, and how we're looking at data that's from this definition or that definition. And then just practically, organizational, the money. I was speaking a little bit to earlier to one of my colleagues. It's really, it's really hard to do any kind of scientific progress when you're just trying to give your patients a standard of care treatment that they need to get. And then one of the biggest things, and I think this is my lesson also learned from the Polar study, it was such a huge global effort. But, when you think about it, like, how can we carry on doing those kind of trials? And that's really for my summary slide. The targetable mutations are really limited to a tiny, small percentage of patients, and this really makes drug development challenging for all of us. And this tumor-agnostic approach has really facilitated drug development, but we really need to think, I think we need to learn to think out of the box. So, like, how are we doing drug development, novel trial designs, in a different way, looking at real-world data, because we can't carry on to doing it the way we're doing it right now. And just really thank you to the organizing committee for having me here, and it's a real pleasure. And it's nice to see people as well, and not just to see my screen. Thank you.